All right. Hello, everyone. Today we're going to talk to you about a project that we've been working on with Dr. Lloyd. This systematic review aims towards changing the standards of care with future meta-analyses rather than prospective data collection and focuses on the impact of hospital walking programs in older patients. I'm sure that many of you have been inside of a hospital room before. If I asked you what the first thing that you noticed was, it would most likely be the bed. Quite simply, this answer is not a surprise, but rather an expected outcome. Patients spend the majority of their time in bed because it's what we've designed to occur. Even the TVs in hospital rooms are mounted on the wall, so if a patient wishes to watch TV, they must first commit to laying down to do so. This is understandable as the culture of bed rest is a standard in modern medicine. However, it directly contradicts a key component of healthcare, which is hospital mobility. Hospital mobility is a concept that's used to measure a patient's level of mobility throughout the duration of their stay. Let's take a moment to look at why low hospital mobility is so far from desirable. Hospitalization is a terrifying experience in most instances, but for older patients, it takes on both a new level of risk and a new level of fear that the activities of daily living we take for granted will no longer be obtainable independently post discharge. Quite simply, patients are walking into the hospital to receive treatment and are being rolled out after discharge. While bed rest is important, it fails to account for specific population needs in order to prevent disability. This is exacerbated in older patients as they're already suffering from the issues which come along with normal aging.
So when we think about a hospital, we either think about people lying around in beds or being wheeled around. We don't really think about people walking from place to place. They're normally in a wheelchair when they're transported around the hospital. There are barriers that are associated with hospital mobility. There are physical barriers that include pain and muscle weakness of the patient, fatigue, and presence of a catheter or other medical barriers. These physical barriers don't let the patient be active, and they might restrict their movement already. There's institutional barriers, including insufficient personnel and insufficient supplies to aid in mobility. I'm a pre-PT student here at UAB, and shadowing in the hospital, this is one thing that I saw all the time. You know, the physical therapist had to be the one to get the patients moving. You know, the doctors and the nurses and the techs didn't really have them moving around a lot. So there's also low hospital mobility risks. These include falls, functional decline, and hospital-associated disabilities. Some of these low hospital mobility risks include getting bed sores and then muscle atrophy, because when you aren't moving those muscles and you're just laying in a bed all day, the muscles actually get shorter and tighten, leading to muscle loss. And when a person comes into the hospital walking, they might not leave walking because they've been sitting in the bed so long. So what do we do about this problem? Hospitals have implemented hospital walking programs that are individualized programs, typically completed under the supervision of a medical professional, which strive to increase hospital mobility and prevent the likelihood of muscle deterioration and HAD. Walking programs are progressive, so they might start with just regular ankle pumps or just moving the legs in the bed a little bit. They might progress to moving the legs off the bed and onto the ground and doing some steps to just raise the knees and get some muscle activity there. And then it might progress into standing up, into walking, and even walking around the hospital or the floor that they're on. There are certain benefits associated with this that include promotion of hospital mobility, decreased negative mental and physical outcomes, promotion of independence in older patients, decreased length of stay, and decreased hospital expenditure due to decreased complications and length of stay. One thing that we do not think about is that most of the time we think it's the doctor's responsibility to deal with the patients in the hospital or the nurses or whatever, but there's also an aspect that family can be involved in hospital walking programs or mobility in general. If we teach and have a little bit of active teaching at the beginning by the doctors or the physical therapists saying that their family member needs to stay active, we might actually help this problem here. There are also different types of hospital walking programs. These can include hospital settings, which are acute care versus ICU. Acute care is more interventions are based on getting more balance and walking a little bit, but the ICU interventions normally have people on ventilators, so it's more just keeping the muscle tone and not having them deteriorate further. There's also a difference in patient population, post-surgery versus acutely ill. In post-surgery, you mostly have people come in that are walking, they're just going in for surgery, and they might come out not walking because they've been sitting in the bed for so long. Acutely ill normally means that people come in with an illness already that has them deteriorate a little bit, and we're progressing their symptoms into not getting better.
Since 2001, many studies have assessed the impact of walking programs on health outcomes for older populations, but to our knowledge, no one has completed a meta-analysis or a systematic review on this topic. This causes it to remain unclear whether hospital walking programs are beneficial for patients across geography, time, and population. To combat this, we designed a systematic review using an explicit process to gather all published peer-reviewed works that address the following two research questions. What is the benefit of hospital walking programs for older patients, and how much do older patients mobilize during hospitalization? In collaboration with a librarian, we developed relevant search terms surrounding our research questions. This enabled us to perform a mass search in relevant databases. These results were then compiled into a platform called Covidence, where we collaboratively screened the abstracts and the full text. 2 people were required to approve each paper based on the eligibility criteria pictured in this flowchart. We asked ourselves the following questions. Did the study include participants 65 years or older? Were participants hospitalized? Did it assess walking amount or some provision of walking program? And lastly, did it take place in an acute care setting? If the answer to all of these questions were yes, then the study was included. This is an image of the Prisma diagram that we implemented in order to provide an accurate depiction of the reviewed research. These diagrams are often used in systematic reviews and meta-analyses because they are easy to follow and clearly state the inclusion-exclusion criteria. 3,267 relevant articles were identified in the initial database search, and 2 articles were hand-selected by an expert reviewer. After duplicates were removed, a total of 3,206 sources remained for the eligibility criteria screening previously described. Full texts were further excluded due to a variety of reasons, such as wrong population, wrong intervention, wrong setting, or simply no full text provided at all. Out of all of these, 10 studies were identified as reporting length of stay as their primary outcome and therefore will be included in the future quantitative meta-analyses. Surprisingly, only 3 studies described the amount of walking while in the hospital. This limited representation in literature furthers the overall gap in knowledge mentioned earlier and provides a specific target for future research to address.
In general, reduced patient length of stay means that people are healthier and they're getting better faster. Our hypothesis is that walking programs do impact length of stay. This will ultimately tell us if walking programs should be a part of this current standard of care in the field of medicine. Our group will continue to work towards meta-analysis completion. We are also working towards finding and analyzing data that can be used to determine impact across multiple populations and time to achieve the highest level of healthcare utilization and efficacy. We would like to acknowledge Dr. Christine Lloyd for her mentorship, the SR review team, and Kay Smith, as we wouldn't have been able to complete this project without their assistance, along with Dr. Cynthia Brown, the School of Health Professions, and the Biomedical Sciences program for their continued support. And thank you to all of you as well for lending us your time today. And with that, we'd like to open it up to any questions anybody may have.
Well, I'll chime in first to say that was a great presentation. Really enjoyed that. This is kind of a question for all 3 of you. Since this is your first time presenting, what was your biggest challenge conducting this research?
In my opinion, our biggest challenge conducting this research under the current circumstances is that we haven't really been able to meet each other in person and talk face to face to bounce off ideas. It's been a little difficult trying to prepare both information for the presentation, but also just to get to know teammates as we're working together, doing everything online.
Excellent. Anything from the other two?
I think also, coming into this project in the middle was also interesting because we had Dr. Lloyd explain to us all the work that she's previously done, because she was telling us at the beginning that she started this in, I think, 2018. So it's not like this is at the beginning of it, we're in the middle of it, and now we're doing data analysis and coming in at the middle. And we're like, okay, Dr. Lloyd, let's explain this. Okay, let's go, let's jump onto this. So it was interesting trying to figure out where we're fitting in and what was already done and what we're going to now.
Excellent. And Jerry?
I completely agree with everything they mentioned. I came into the project a little earlier than Tara and Kylie, so I participated in a lot of the methodology, but I loved getting to know them because they're older and more experienced, and learning a lot about the biomedical program here at UAB.
Fantastic. Any other comments or questions? We did get a nice compliment in the chat. You're welcome to throw them in the chat. I see Dr. JeriGrundhoefer with us now, and she has her mic off.
Yeah, I have a quick question. So I've done some systematic reviews with Dr. Lloyd as well. So I guess my big question is, how do you guys feel the data extraction is going, and how long do you think that it's going to take before you can finish completing data extraction and actually get the results? Because they seem really important, right? If we need to get patients moving around the hospital, that is important. But so how long do you think this is going to take?
So statistical analysis right now being done by the expert statisticians is really going to kind of determine how we're going to complete the project moving forward. If we get a value that's above the value of significance, we'll definitely be able to move full force ahead with our plans for the meta-analysis. If the value is under significance value, we'll most likely return to find other alternative resources and more data to kind of strengthen this before moving into latter phases of research.
And ironically, Dr. Lloyd actually sent us the research a day ago and the actual statistics with it. We did not include it in the presentation because we would like to go back and actually talk about it more and figure out what is important. But we are close to being statistically significant. It's not quite, we cannot say there's a causation. We can say it leads to slightly of, more walking leads to a decreased length of stay, but it's not quite statistically significant. And we also had a difference in getting mean values versus median values. So if we have the ability to go back and change those median values into mean values, so we can add in a couple more studies, then we might be able to get to that point where we can actually say that there's good research and there might be a correlation there.
Kind of help bolster that. It basically, there's a trend. There's a trend for walking programs to reduce length of stay. We don't have a significance, but that's actually only using 8 of those studies out of the 10. So yeah, you guys nailed it.
Tyler has a question.
Yes.
Go right ahead.
Actually, I have a couple of, just a comment and a couple of questions. First off, fabulous job. Really, really well done. And then I have a couple of questions, one kind of about your research, and then another one I'm just curious if you may have an idea. So the first question I have is kind of based on a couple of the comments that you guys have been making. Is there anything that you have done or that you have discovered that was kind of surprising about what you're studying, or just really about research in general, right? You talked about maybe the difference between causation and correlation and how that line is kind of fine, right? That are there things that you have that, like I said, have surprised you? And then the second question I have is, early on, you mentioned some of the potential barriers. And again, knowing that you haven't really done this research yourself, but are compiling it, I'm just curious if you noticed in the research there's any resistance to this kind of thing, because it kind of goes against convention, right? That as you mentioned, there are beds in the room, everything's set up so the patient is just bed rest, right? Has there been any that you've noticed, any sort of, like I said, resistance to that from kind of medical personnel? And like I said, I don't know if you would know that, but I'm just curious if you have seen that in literature at all.
So I can respond a little bit to both of those. One thing that surprised me the most doing this research is the heterogeneity of the current research that we've found. It's very difficult to find research that all uses the same type of intervention methods that measures the same thing. So the difficulty level of that, I will admit, was not something I was fully prepared for. In terms of barriers to this, there is some pushback from patient healthcare providers only because they already have so many other things kind of on their plate that they're also trying to juggle. Actually, UAB Hospital Highlands acute care for elders unit is actually a really excellent example of people that are taking part in leadership training and specialization training for physical cognitive needs of older patients. And it's actually teaching them how to offer it, how to encourage it, and how to kind of make that a unit-wide thing. So I think that they're a very good example of what we're hoping to eventually reach, is establishing that in multiple units everywhere.
I would like to add on, as a pre-physical therapy student, I've done a lot of shadowing the physical therapists in the hospital that do the main mobility. And one thing that I really did notice is that how many patients said, I don't want to get up right now. And you either had to coax them to get up, or you said, I'll come back later. Now, I think that can be improved with having some of the nurses do it, and even getting family involved. Dr. Lloyd and I talked about how, maybe this shouldn't be an issue with the hospitals. I mean, it should be, but also we can educate, if we take 5 to 10 minutes at the beginning of their stay and educate the family on how to keep them mobile, even turning them over type of thing, of getting them off of one side of their body, getting them off their muscles, and even just doing ankle pumps in bed. That might even help even just a little bit compared to where we are now.
Great, thank you.
Excellent questions and excellent answers and an excellent presentation. So we're at our time limit now. So thank you all for presenting.